more you age on the job. So since the theme is who cares for the carers, the carers have to be concerned about themselves as they are concerned about their patients. So that's that. Now, athletes, if non-professional athletes, hardly come to the hospital. Hardly. That's consultation.
Thank you very much, Dr. Ali. For Dr. Fatade, the question, should x-rays be done at first contact for a patient with back pain? Should I say it again?
Well, like I said, it depends on who is seeing that patient, and we must have completely examined the patient and taken relevant history. But I agree that if that has been done, then you can order for an x-ray. But if the symptoms is heavy, is severe, you may need to go to MRI because there is a limit to what an x-ray can show you.
Dr. Ojo, any correlation between knee pain and spine pathology?
Thank you very much. I was actually thinking Dr. Halimi would have been in the best position to answer that, because I think, and I've seen a few, without going too far into your specialty, at a point it becomes catch-22. If somebody has a back pain, he will struggle to walk. If the pain is more on the right, he's going to lean more on the left, thereby wearing off his knee. And if the knee pain started first, he's going to try to shift the weight to the other leg, whereby tilting his back or his spine in a way that will make his disc wear off quicker. So sometimes a patient would come with the two. He's got a back pain, he's got a neck pain. Which one do I do first? Which one is more of a problem? Essentially, the patient would need to have the two done. Maybe at different points, but maybe about the same time. Otherwise, sorting one problem, leaving the other, will make the pain come on the other side. So yes, it can be correlated. And it has to be clearly defined. And I've seen some patients too, whose primary problem is the knee. But because he has been kept for so long on pain medication and has been trying to dodge it, now he's having the back pain. So when you see the patient, you may be able to tell which started first, which is more of a problem, and then eventually the two has to be solved.
Thank you very much. Dr. Ali, back to you again. Please, could you, go sort of give us, more insight into sitting position and hydration in low back pain?
I'm not sure that question is very clear to me, but I will try and answer it to the best of my knowledge. The truth is that hydration is, if you read about aging and gerontology, most of the cells that they talk about wear and tear, they always add hydration to it. They'll say it loses water. Muscles lose water, so it's aging. Tendons lose water, so it's aging. So hydration, to an extent, is synonymous to your reasonable lifestyle. If you register in a gym where you work out, any reasonable gym, they won't allow you get in without a bottle of water. They will insist that you take a bottle of water in as you are getting on the treadmill, as whatever you are going to do, go with a bottle of water. Whoever the gym instructor there is going to instruct you, try and drink as much water as possible. So hydration, water is life. Now back to what I understand your question to be. When you sit, you transfer the load in the back to the axial. You put the load on the bones, on the vertebral body, and the disc. The moment you're sat, your disc squeezes out water. And it remains like that. When you stand up, it imbibes water again and returns to its, at least to its original position. Let me put it like that. Now, for the existence and normal function of that disc, you need to maintain that cycle at reasonable interval. Once your cycle of load is extreme, when it's going to imbibe water, it's not going to imbibe so much. So it will start degenerating faster. It shows that his disc is desiccated. For that age, at that particular disc should not be desiccated. They are there for 5 months. So you know that he's a sitter. And that's why I find most reasonable corporate environment encourage you to move around. Some of them will even run exercise regimen for you on a weekly basis or weekend. They encourage you to move around because the body is not designed to sit; it's designed to move. If you are designed to sit, this is how God will leave it for you. You can't just sit, but it's designed to move.
Well, thank you very much. Dr. Joy, what is the effect of spinal anesthesia on spondylosis?
I'm actually trying to
Understand?
understand. Of course, I know what spinal anesthesia means, but not everybody gets it. You probably get it if you want to have a procedure done. I am not sure that people that had spinal anesthesia for whatever reason, childbirth, angiography, or whatever, will have spondylosis. I don't think scientifically, I could be proven otherwise, that there is a correlation. Also because you don't go and get spinal anesthesia every day. Even for people that are having children maybe once every 2 years and after some time they stop. I don't think men would just go and have spinal anesthesia without any procedure to be done. So I don't think that anybody who has spinal anesthesia for whatever reason will come down with spondylosis. The pathogenesis of spondylosis has been well and clearly demonstrated. Aging process, increased activity, sitting for so long, desiccating the disc, and so on and so forth. In all of these that have been known, I don't think that spinal anesthesia is a factor in making it worse.
I think I understand where the person is coming from. You have a lot of women who say that after they had spinal anesthesia, either for childbirth or for a procedure, they have back pain. See, Dr. Cecilia, I had that spinal anesthesia. I've been having that back pain. I think it's just a coincidence. And it's typical of our patients to relate their situation to an event. A patient tells you a story of a knee joint. You say, you remember 20-something years ago when he was playing football, he just fell, somebody kicked him, and since then, this problem has. So our patients tend to relate their pathologies to an event around that place. But there is no documented correlation between spinal anesthesia and low back pain, none whatsoever.
Dr. Alimi, you again. Back stretch exercises, can these resolve back pain?
Look, back stretch exercises are very good. They serve several functions. One is that they increase the tone of your back muscles. That's number one. Two, they make your back ligaments more supple. Three is that they increase the range of movement of your joints. So let me explain that in details. So if anybody who has a well-toned back muscle, when he moves in elegance. His body moves as one solid good structure. If the back muscles lose tone, which happens to a lot of people in the age of those that are in this room now. So when you move, especially when you turn in bed late in the evening, your back does not turn as a whole entity. So maybe the proximal, the part close to the head is turning, has already turned 90 degrees. The lower part is still turning 40 degrees. Now put some strain on your facet joints and other parts of the body. So you feel pain. That's why. If your ligaments are supple, you can sit in a reasonable position without feeling discomfort. You can take stands, you can stand, you can move elegantly. So there is nowhere in the management of low back pain, back stretch exercise is an integral part. When I was talking, I said your physiotherapist is your friend. Those are part of things they are going to teach you in the back school. So it's very important.
Another question for you, Dr. Two, what is referred to as appropriate supplements? One. Do we then give vitamin D3 and calcium as regular preventive drugs daily?
Okay, this is it. In the United States, any woman that is perimenopausal, in the past, vitamin D and calcium was one entity. Now you have vitamin D that is sold separately from calcium. You have them, usually the combined one, the calcium 600 milligrams come with about 400 international units, some with 500 international units of vitamin D. If the woman becomes perimenopausal, she should be on at least 2000 IU daily. That's what they recommend. Some of them are wild enough to say 5. That's why I'm not saying 5. But they do that. And the whole idea is that you want to reduce the effect of osteoporosis, especially on women. So that she doesn't come with microfractures, compression fractures, that you start things that you can prevent. In fact, the argument is that you start loading them as children. So that by the time they are getting to 40, 50, they have good bone stuff. When they start losing, it does not make so much of an impact. It's safe. For them, they are pushing it very strongly. So I recommend it. Most of my patients who are perimenopausal are on at least 2,500 IU of vitamin D3 every day.
Thank you, Dr. A question, comment from you, Dr. Ojo, concerning physiotherapy.
Thank you very much. Dr. Halimi has already spoken about the significance of physiotherapy and physiotherapists in the management of spondylosis. My concern is this. If somebody has a broken ankle, you will rest the ankle. If somebody has a broken elbow, you'll probably rest that elbow. If somebody has spondylosis, for instance, in the cervical spine, it is not the time to do physiotherapy for too long. If somebody has spondylosis, no, let's not say spondylosis for now, because we haven't made the diagnosis. Somebody has low back pain, until we are sure it is spondylosis, and there's nothing else being cooked in that back, we cannot use physiotherapy for too long.
The last word I'll say here is that as physicians, we need to evaluate our patients very well, and we need to investigate our patients before treating them. It is not enough, because right now, the world is going into evidence-based medicine. There must be an evidence for what you are treating. Don't let us treat in the dark. Let's investigate our patients appropriately, and let us be sure of what is there and what we are treating. Thank you very much.
Thank you very much, Dr. Ade. On final note, there was a suggestion that we all stand up, since we've all been sitting. So we all stand up and taking Dr. Alimi's advice, walk around 1 minute, 1.5 minutes, or 2 minutes, shake hands, and come back to our seats. Thank you.
Esteemed panel session members, thank you so much. That was a wonderful one. Please remain on the top. Yes. Remain on the top disc. I'd like to. Where's it? Thank you, Ma. That was really good. Thank you. All right, we're meeting ourselves. On behalf of the organizers, I want to apologize that we couldn't take all the questions due to time.
Come forward a little bit. Both of the lights. Come
There will
forward.
still be time to interact with our esteemed panel discussants. interact with them.
If it's not so informative, the question will not be headless. And I want to apologize that we could not take all the questions that were just coming in and coming in and coming in, because there is going to be a section for this. And we promise you that we'll bring this on more regularly. The exercise, again, I want to apologize that it has taken 2 minutes of our time. I'm very sure if the MC had to do that exercise, he would have asked us to stand and dictate some form of exercise for us rather than allowing us to exchange greetings. That would take a lot of time. But okay, we're doing well. I want to use this opportunity to appreciate Dr. Fatade and Dr. Alimi. Dr. Alimi, are you still in the hall? Yes. Please don't go yet. Please, no, don't step out. Please bring Dr. Bajimi, you are taking Dr. Alimi away. And Dr. Fatade, please, can we put our hands together for these 2 gentlemen? I am saying this because exactly what Dr. Alimi presented, we have one of our elders that had that problem. And the first person that actually came to my mind was Dr. Fatade. We did an X-ray, we found all sorts of things, and he immediately requested that we should do an MRI. And we did an MRI, the problem was seen. Dr. Alimi came in, reviewed it, and said, this treatment will not need surgery. This will not need all your normal analgesics that you have been taking. Right? The only drug, because the pain is nociceptive pain, we just switched from the regular NSAID and other to the nociceptic, and the patient had flown abroad, came back, and is working regularly. Why am I drawing this attention? Number one, the cost of those investigations was given to Agpmpn for free. And that's why I need to appreciate Dr. Fatade. The consultation, the treatment was given equally for free by Dr. Mustafa Ali for this, our elder. And the primary physician saying has been seen as a superman that have changed the narrative of surgery to physical treatment. So I'm saying that if you apply yourself to your other colleagues who are specialists in that network, the glory will never be taken away from you. And that's the preaching. And that's what we're supposed to learn here. They are there to support us. But we must engage them. And that brings me back to one of the statements that was made. Please, when filling the request form, please fill properly. Your name, most likely your specialty, put it there, and your phone number. Because if you refer appropriately to the appropriate lab, when they see anything, they will call you to tell you either it's emergency or what you need to do. They're not teaching you. But to me, I believe they're teaching me. But don't see it as if they are bossing over you. But they are helping you to apply yourself very well to your patient. And that is what will bring out the quality in our service. So I want to thank you very much for what you have done. And that is the essence of our colleagues, and that's what we're doing. Lastly, as a fallout from that interaction, we have made up our mind that we have started, we have discussed it, but we are still re-emphasizing it, that we are planning and health plans for practitioners in Lagos State. Agpmpn will be responsible for those investigations. It is not a regular test that you pay the cost. They are also bearing the consequence because they are also going to be part of it. And Agpmpn will pay on our members that have attained those age, and we'll be doing it regularly until we build up the fund in the welfare thing. Sometimes they ask us to pay welfare, we think we are spending the money anyhow. We're not. This year alone, we spent close to 10 million on welfare. And I want to explain it because you know very well. We had 2 surgeries for some of our doctors in Lagos State that cost us a lot. But the joy is that you're seeing the results, and our colleagues are getting very much better. So I want to thank you for the support you have given this administration so far, and we hope to get more. Thank you very much.
Thank you, our esteemed Agpmpn chairman. Please make sure you fill in the forms appropriately to access all he has for you. Informed that women are smarter than men. I don't know. Do you agree? All right. Okay. So I'm not sure yet. So I'm going to ask you. I mean, a woman's best friend is what? Who knows? Woman's best friend. Who knows? Did you say the husband? Okay. What else? I'm talking about something intangible. The purse. The purse. Money. What else? Mirror, what else? More money. Okay. The answer I'm looking for is jewelry. Diamonds. Diamonds and woman's. Okay. Now what's a man's best friend? A man's best friend. Nah, let's go. We know it. A man's best friend. Yeah. Let's try again. A man's best friend. I'd like to invite Dr. Omotayo Ojo, consultant neurosurgeon from LUB, to talk to us about the advent of modern neurosurgery in Lagos. Let's give him a warm up. Thank you.
I'm a consultant neurosurgeon at Lagos University Teaching Hospital. So I'll be talking about the advent of modern neurosurgery. I think about 15 years ago in Lagos, we could do general neurosurgery. And when I say general neurosurgery, I mean more of trauma, chronic subdural hematoma, perhaps few extradural, very, very little spine surgery, especially in trauma. Complex spine was practically not possible then. If you could try, and I had cases whereby they said somebody would go for surgery walking, but will come back either in wheelchair and sometimes in body bags. Neurovascular surgery was almost impossible, and complications of neurosurgery was enormous. It was so bad that I hear people saying that, well, it's 50-50, when you go in, you don't come back. Or if you come back, maybe not as well as you went in. And even up to now, people still have that notion, but I'm sure by the time I'm done with the presentation, you will see that a few things have changed. Also then, you will know that there are probably 1 or 2 CT scans available. MRI was so poor, it was like using Nokia 3310 to take pictures compared to what we have now, 1.5 Tesla. Operating theaters were probably not interested in complex surgery. They were just okay with few that was possible, and very few invested in appropriate tools. Neurosurgery now, at 2019 and forward, in the past few years, most cases can be safely done, not only in Lagos, but in a few other places in Nigeria. Facilities are available, and more are still coming. Expertise very much available. Because of reverse brain drain, people trained abroad, came back, even locally trained guys are doing a lot of activities. Unfortunately, many are unaware of this development. patients suffer unreasonably, and some die because of ignorance. I once had a patient sent to me who had ventriculoperitoneal shunt done in India. The diagnosis was made here in Lagos, and the parent felt, no, we can't do it in Nigeria, so they took their time, queued up at India Embassy to get visa. I think it took about 2 weeks or thereabout, and please realize that every day the head gets bigger, and they had to travel to India only to come back with complication. And that was when they got to know that this could be done in Nigeria. And this surgery took 1.5 hours. The time he would drive from Lekki to international airport before he could fly. So some died because of this ignorance. There is a move now from open surgeries to microscopic surgeries. Well, I didn't say earlier on, I am more of a microneurosurgeon, which quite improved the outcome. The surgery is faster, the patient safer, less hospital stay, less comorbidities. The standard operating suits now for neurosurgery, well, good theater, not sure the image is very clear. This is from Genesis. Good theater, good ambience. This is an operating microscope, which makes neurosurgery fun, makes neurosurgery safer, quicker, and more predictable. This is a C-arm. It's impossible to do a spine surgery without a C-arm, because you need to localize what you're doing and need to be sure the screws are well placed. Of course, we could try without these and manage the complications, but nobody wants to get it wrong the first time. So the C-arm makes it better. This is an endoscope for endoscopic surgeries, and tower in the theater to make life easier for the surgeon. The supporting structures are well available in many places, and these are what will be necessary after the surgery to ensure that the patient would go home better. And these, in the few years, are available, and this is also at Genesis. This is an ICU, an in-suite ICU, just one patient, the monitor there, oxygen being piped to the patient, and so on and so forth. Well-trained staff, we have them in Nigeria now, adequate level overnight doctors. You see, we are always as good, especially in neurosurgery, wherever it is practiced, teaching hospitals everywhere, we are always as good as the strongest link, as the weakest link. If the overnight doctor would not know what to do after surgery, if he would not know how to pick somebody in distress and he had to wait until the following morning for you to come back and make a decision, you will realize that the patient might be long dead before you come back. Supporting overseeing consultants will be very necessary for a safe neurosurgical practice. So I will talk about a few cases because I know I have very short time. And these cases will be the flag point, just to let you know that neurosurgery has moved beyond 50-50 to something like 95 or something better than that. Aneurysm is probably not as rare as people think. In places where they keep records, they find it quite commonly than we do here. And it's possible because we don't make that diagnosis. A patient coming to you telling you that he's had the worst headache of their life has had an aneurysm, wherever the patient is coming from. And this statement is common whether it's in England or US. They will come that this is the worst headache of their life, and they could actually tell you the time it happened. Actually, that would be the time the aneurysm ruptured. And male and female, I'm not sure which one has it more, but you probably must have seen some of them coming with such worst headache, or probably you have had. I once had a patient, a man who went with somebody's wife or another lady somewhere, and in the middle of the night, aneurysm ruptured. Now, you know what that is called in this environment? Unfortunately, that is why they will not come to the hospital. So when I started questioning him, because, well, he was well-to-do, he came early, the story is that it happened, it has some spiritual connotations, and because of that, they don't come to the hospital. Or a woman, I think this particular lady came in December, came from England, and came to Nigeria and was fighting her sister. and it was at the point of shouting that the aneurysm ruptured. And it took a while to be able to convince her that this is aneurysm, but not a spiritual attack. And these are the factors that probably will make patients not come early. But when they don't come within 48 hours, they will almost always die from ruptured aneurysm and complications thereof. Only surgery will help. There is no room for conservative management in an aneurysm. And the higher they get to a neurosurgeon who could clip it, the higher the chances of survival. And well, more patients are now coming, and this is possible both in the public hospital and in the private hospital that has the facility. Like I mentioned earlier on, the microscope, which is a must for aneurysm, and the ICU. So this was the lady that I mentioned that was fighting her sister, and this was another aneurysm in the area of Agpmpn region of a man who, you know, and so on and so forth. Spine had gone beyond 50-50 to probably 98% now, except something terrible happens or the comorbidities are enormous. You can safely say that you will go and come out and within a week back to whatever you were doing before. So it's now routine in many places. Laminectomy, microdiscectomy, even complex spine surgery with increasing number of patients being done in Nigeria in general and Lagos in particular. Private, public, everywhere, it is now being done. So a few cases, a slip disc, I think he was about to lift something and he heard the usual noise and he had to stay there for a while until the MRI is done, and in this case he would have presented with weakness, foot drop and so on and so forth, and that is the disc out. And within a week he was back home, and in 2 weeks he was doing everything he would have wanted to do. Complex spine surgery, degenerative disc from spondylosis, who was so bad he had to be operated with screws and rods and became better afterwards. Another case of metastasis, Dr. Alimi was saying not all back pains are from spondylosis. This was a metastatic tumor. This one was done recently, I think in the past few months, and with screws and rods, and it's back on his leg and better. All these cases were done in Nigeria here. Functional neurosurgery, epilepsy surgery is now becoming common. In other places, 10% of patients with epilepsy will be recalcitrant to anti-epileptic drugs, and 10% of them will need surgery. And we've done a few. It's now becoming common in my practice, and I think we've done a few too at Genesis with fantastic results. There was a guy who had been having seizures for 18 years, and after the surgery, no seizure till date. When they are well chosen and the surgery goes very well, no seizure comes afterward. Another area that has been so fantastic in the past few years is pituitary surgery. I'll tell you that 20 years ago, pituitary surgery had to be done open in Nigeria. You would know that the complications are terrible. Because to get to the pituitary gland, you have to open the brain, lift the brain up, the frontal lobe, open until you get to the cellar floor and take out the tumor, probably with your naked eye. And many of them don't make it, so afterwards become vegetable with terrible prognosis. But now, we don't do open anymore. Not in my practice, and not in the practice of people that I know, well in Lagos. We do transsphenoidal with good outcome. They go home within a week, which is the standard of treatment now. And what, I'm not sure we could see this very well because of illumination, but this is how a pituitary gland will look when we go through the nose. This is the pituitary gland here. So going through the nose means I'll put a speculum there, and I'll be at this floor under microscopy. This is pre-op, and this is post-op. This is possible. I'm sure this was done actually in Genesis, but it's been done in every other places in Lagos. The advantage of microscope is that I could spare the pituitary stalk. Because with naked eye, I won't see the pituitary stalk, and I'm just going to yank everything out. And after the surgery, it's having problem with urination, problem with erectile dysfunction, and so on and so forth. But with microscope and with good instrumentation, I could spare the pituitary stalk, and patient goes on within 2 weeks, within a week, and after 2 weeks, back at work. Brain tumor is now so routinely done that we can safely say that you don't have to travel abroad for this. And I will show a few. Meningioma, tuberculoma, posterior fossa surgery, and glioma. Olfactory groove meningioma. This is like a quarter of this patient's brain. This is pre-op, this is post-op. This is pre-op, this is post-op. And they do very well when appropriately done. And within 2 weeks, you will never know they've had surgery. I didn't mention that for pituitary surgery, they don't get a scan. So if they don't tell you, you don't even know they've had a pituitary surgery. Brainstem tumor with microscope, endoscope, and so on and so forth. We used to refer to brainstem tumor as untouchable until recently. It can be done, and it's being safely done. Foramen magnum meningioma, terrible disease to have it instrumentation, it is a no-no. And these are now routinely done in Lagos. This was a case of tuberculoma, pre-op and post-op. And patient is doing so well. Pediatric surgery, I mentioned VP shunt, endoscopic third ventriculostomy, I showed the endoscope earlier on. These are the modern neurosurgery that is being done elsewhere and currently can be done in Nigeria and is being done with good results. Trauma, we know trauma, it happens, head injury, spine injury, but the catchword is time. The higher the patient is sorted, the better for the patient. There was a lady, 18 years of age, who was going to meet her mother, the only daughter, the only child of the family, road traffic accident, broke her neck. And when I saw the mother, and I was telling the mother the day of the incident, that look, this lady needs surgery. And he said, no, there's no money. I told her, if this surgery is not done today, because the cord was compressed, she would never walk. And she did the reasonable thing. She went to Balogun, sold her gold, came back with money. We did the surgery that same night, and within 2 weeks to 3 months, we were able to rehabilitate her. She's walking as if nothing ever happened. If that surgery was not done within 48 hours, she will be on wheelchair forever. These cases are being done in Nigeria now, which 15 years ago, she would have been confined to a wheelchair or would probably die from complications of injury. This was another case of trauma. You could see the fracture there, and you could see the plates and screw just to realign the bone. I would say not all of them would walk. In this case, he would never walk because the cord was completely transected. But he could sit, possibly use the hand, may never be able to use the leg, but the rehabilitation is better. So it's also part of management to manage those that will never walk but can sit and move on with life. Or otherwise, would have been on bed with bed sore until something else happens. So the take-home message is, number one, healthcare, especially in neurosurgery, and I think in other specialties, has moved significantly in the past years. To the extent that we are now at the forefront, what could be done elsewhere, we're doing many of such cases. Teaching hospitals are able to sort out many neurosurgical cases, especially when they come on time. And we all know the problem with public hospitals, work overload, waiting time, and I would say that private hospitals in Lagos are now doing a lot of stuff that we're doing in the private hospital, just because they've been able to get the facilities so that we could do them. Hospitals can handle extremely complex neurosurgical cases. Aneurysm is at the peak. Functional neurosurgery is at the peak. And complex spine surgeries, which I've shown you a few. The facilities and expertise are very much available. Some patients will require urgent care. Not all cases can be referred. The lady I mentioned about the other time came from England. And so when she had an aneurysm and she thought it was a spiritual attack, eventually she was convinced it was an aneurysm. And she said, no, she's not going to have it done in Nigeria. You see, there are some things that when it happens, even if you have all the money, you can't fly. The airline just told her, you can't fly, you have to wait for 2 weeks. An aneurysm, it will rupture again if it has ruptured once. And when it happens the second time, it will be there until she had to say, okay, well, she had all the money, she was covered, but she can't fly, and she agreed, and we did the surgery, and she became well. She's ever so thankful. Finally, time is brain. If you have somebody that has a brain tumor, or brain injury, spine injury, whatever it is that has to be sorted, it has to be done early. The time to go queue for visa, look for a contact abroad, could tell from somebody who would survive, someone who would survive with significant complications, or somebody who would not make it at all. The earlier the patient gets sorted, the better. And finally, these services are available even in the private sectors. Thank you.